Good afternoon, everyone. Welcome to the Women and Girls Research Alliance October Talk. Welcome to our Breast Cancer and Women's Health panel. I am Dr. Michelle Meggs, and I serve as the Executive Director of the Women and Girls Research Alliance here at the University of North Carolina at Charlotte. The Women and Girls Research Alliance exists to address the critical needs of women and girls here in the Charlotte metropolitan area. And I have the honor of introducing our moderator for this hour's conversation, Dr. Judy Tjoe. And Dr. Tjoe will introduce our very august panel for today. So now I will turn it over to Dr. Tjoe, who will introduce our speakers and facilitators for today. Dr. Tjoe.
Thank you, Dr. Meggs, for the opportunity to lead such a great panel of accomplished women whom you gathered today to discuss the topic of how African American women in particular are impacted by breast cancer. And I thought we would start with some introductions of each of the panelists. My name is Dr. Judy Tjoe. I recently relocated from Milwaukee, where I worked at the last remaining inner city hospital in Milwaukee, to move to North Carolina to serve as the medical director of breast surgery for Novant Health in the greater Winston-Salem area. I completed my medical school training, anatomic and surgical pathology fellowship, and surgical breast oncology fellowship at UC San Francisco. I've been in clinical practice for about 20 years now, and I really enjoy getting to know my patients, educating them about their breast cancer diagnosis, so that she or he is informed enough to be an active participant in his or her cancer treatment options. In my previous role, I was very actively involved in research involving topics throughout the continuum of breast cancer, with a particular interest in predictive biomarkers and the importance of exercise in the survivorship years. And I'm happy to be here with you today. Our next panelist is Dr. Julie Palmer. She is a professor of epidemiology and co-director of the Boston University Boston Medical Cancer Center, working with researchers from basic science, translational, clinical, epidemiologic, and health services research, focusing on cancer health disparities, particularly with regard to race and income, reducing disparities across the entire spectrum of cancer etiology and cancer care. So welcome, Dr. Palmer.
Thank you.
We have Reverend Lettie Ar-Rahmaan, who has a double master's in computer science and divinity, which places her in the very unique but perfect position as a tech consultant for Ministries. She also brings to our panel the most valuable perspective of a survivor of stage 2B breast cancer. So thank you, Dr. Reverend, for your candor and willingness to share your personal experience.
Thank you.
And then finally, we have Dr. Monika Sawhney, who's a tenured associate professor at the University of North Carolina at Charlotte. She conducts research and she teaches. Dr. Monika's professional and research interests primarily focus on developing innovative digital technology and engineering to reduce the disease burden across low and low-middle income countries. She collaborates with grassroots, non-governmental and governmental organizations such as UNICEF, the World Health Organization, and field-based assignments that have included working with programs in countries such as Austria, Bangladesh, China, Costa Rica, Ethiopia, India, Kenya, Switzerland, Tanzania, Turkey, and the United States. So Dr. Sawhney, thank you for joining us. So to kick off our discussion, I'd like to invite everyone, both panelists and the audience, to the same table with regards to an understanding of the term social determinants of health. This is a term that we've heard increasingly more and more over the last few years. And as health systems move toward value-based models that incentivize positive results rather than individual procedures and treatments, healthcare industry leaders are increasingly regard social determinants of health as critical components to address it in tandem with medical care. Social determinants of health include conditions such as the places where we live, where we work, where we learn, and where we play. And that affects a wide range of health and quality of life risks and outcomes. This includes employment, housing, food, education, and healthcare, all things that are expected to worsen during these COVID-19 times, and its aftermath, particularly for the poor and the disenfranchised. I know from a clinical perspective, that as a surgeon, regardless of race or ethnicity, the overweight, hypertensive, diabetic woman who's diagnosed with stage 2 triple negative breast cancer, who's also a single mother of 3, maybe living in a 2-bedroom house in a rough neighborhood, works 2 jobs to make ends meet, and has 4 blocks to walk to get to the bus that she uses for transportation, is going to have a much rockier treatment course than the healthier woman with a higher education, strong family, and financial support, who's maybe dealing with estrogen receptor positive disease. And so for the group, I thought we'd start by, from your perspective, sharing with the audience how African American women may be affected by the impact of COVID-19 with regards to access either preventive services or breast cancer treatment. So, Dr. Palmer, do you mind if we start with you?
That's fine. I can speak to that question with my own experience at Boston Medical Center, which is where I'm located. Our hospital it used to be called Boston City Hospital, and it was the city hospital. It was about 20 years ago, the city made an agreement with the university for it to become a private hospital that would continue to be the hospital that serves the underserved in the Boston metropolitan area. And so what I witnessed over the last 6 to 7 months was our hospital had the highest proportion of cases of COVID of any hospital in our area, and only one other hospital, Massachusetts General Hospital, which is 4 times as large, had more patients with COVID than we did. But at a certain point, all of our beds were occupied by COVID-19 patients. And what that meant was we had to shut down everything else. And it meant that women who were newly diagnosed with breast cancer could not start treatments. And I was shocked. I'm not an MD, so I'm not taking care of patients, but you know, I've watched my sister go through breast cancer and metastatic cancer over the last years, and I really understand how important treatment is and early treatment. And I felt for all the women who could not begin treatments and had to have alternative treatments while they waited. And it was affecting more the women who were underserved in general, who would have the hardest time and perhaps have the worst disease, were typically seen at the hospitals who could not see them, whereas someone else who lived somewhere else could go to a hospital that hadn't had to shut down their services. So we now are back up. You know, it's been a couple months now that we've been taking patients, and we have an incredible chief of oncology, and you know, has done a good job bringing things back as much as possible. But that was one very real way that we saw people affected.
Dr. Sawhney, how about your experience? Dr. Sawhney, do you mind unmuting yourself, please?
Sorry. I think I would like to talk a little bit from the preventative services. You know, this summer I had a very small grant with Dr. Michelle's office, and we tried to study the barriers why women do not want to access preventive services. I think in general, there is already a challenge for, you know, minority women or women who are from the different socio-demographic strata of the society. I think with COVID-19, it is going to really impact, because anyways, it was difficult to get women, to convince them to go and get their mammograms done. But now what's going to happen is with COVID, and as Dr. Palmer correctly mentioned, all other services are put on a back burner. So preventive services, people are like, oh, I'm advised not to go to the hospital because of COVID. I don't have resources. I lost my job. I don't have insurance. I am managing childcare and jobs from home. So I think because of COVID, because of the medical as well as the social determinants, it's going to further hinder women seeking preventative care. And I think if we do not have preventative care in place, getting them to the treatment level is going to be very, very challenging.
Yeah. And Reverend, from your community perspective, what are the perceptions and concerns about the community coming back into the healthcare system as we start to ease back into screening, mammograms, and breast cancer treatment?
Well, I want to kind of take it from the treatment standpoint. I have one of my best friends who developed cancer late last year. She was going through treatment at the height of COVID-19. Her concern was how does she stay safe? And we talked about how to stay safe. So she would, whatever clothes she went in with the hospital in, she sterilized everything and had another set of clothing on the way out. We talked about taking care of that. But then the other side for this treatment for us is basically childcare. Transportation, as you were talking about earlier. Transportation might be more than 4 blocks because living in North Carolina, it's not the same city blocks. So that's a different an obstacle and a barrier for us, especially when transportation is relied upon on bus. And then if a lot of people use some of like Uber or some of the other services, then that was very cautious. So they would not be able to get back and forth to their appointments without having someone present. Many are caregivers in the community for their families. So a lot of that is the barrier that's going forward, and the biggest piece is, how do I remain safe during my treatment? Who's going to take care of my child? Is there a support group for me? Those are the things that we are seeing during this COVID-19 that's impacting that treatment.
So I can say from a clinical perspective, with regards to screening mammography, we are spacing out appointments so that there's no overlap in the waiting areas. We're thoroughly cleaning rooms between exams. We've increased our hours so that we can actually make up for the patients who had to put off their screening mammograms when we initially shut everything down. And then when it comes to actual treatment, getting her surgery or chemotherapy, we're screening everybody beforehand with questionnaires. For those undergoing surgery, we are testing them for COVID and to make sure that if she is infected, everybody can take precautions. And then we're also limiting the number of visitors that can accompany the patient. But how do we get this message to the communities? How do we help provide assurance and confidence that they can come back to their care?
I think me and Reverend Valletta just talked about this over the weekend, that there is a lot of research that's being done, but how do we translate it? How do we implement it? I think one of my successful experiences working in Georgia it was a coincidence that I got to be friends with a lady from African American descent. And she said, Dr. Sawhney, if I hadn't met you, I didn't even know there was something called mammograms. And it shocked me that she didn't even know what was a mammogram, forget about getting it. So I think it was more of a personal connection. I worked with the church. I went to their, service that they have on Sunday. I had the pastor, give me an opportunity to talk. And we were actually able to encourage 80 to 95% of the women to, get to the mammogram, at least agree that it's, it's nothing rocket science. It's not painful. It's helpful for you. Somebody will accompany you, things like that. And I think, as I discussed also a couple of days earlier, another challenge that we have, it's not just getting the women ready to get to mammograms. I think it's also educating the women about the healthcare cost, making them health literate, that they need to understand their insurance, their, deductibles and everything. Because if you go for a mammogram, you are not health literate. It's what I call not literacy, but, you also need to be health literate. What is covered, what's a 2D, mammogram, what's a 3D mammogram, what is covered, what is not covered. I think getting that information to the people that really need it is most essential, so we don't have, people backing off. Oh, I went for a mammogram and I thought it was covered and I got a bill of $1,500. I am never recommending it. I don't have money to pay it. So rather than avoiding that backslash, I think it's good that we not only educate the women about the benefits of mammogram, but also make them health literate, what it involves, the stages. And I think one of the things, and I think you clinicians will be better to guide on this, I think getting a mammogram is one thing, but the difficult charge comes from the radiologist that reads your mammograms. So I think making the population literate and making them prepared, what can be covered, what are other resources, is very, very important.
Dr. Palmer, Reverend, how do we get that literacy into the community where it's best received?
Well, one of the things is that what I've done, as I was a pastor for about 8 years, so we will hold in October a breast cancer or a pink luncheon. It was actually a pink and purple lunch or a breakfast, because we were dealing both with breast cancer and also domestic violence. And we will encourage each and every woman to go and get their mammogram once. And this is before I found out I had breast cancer. So we were doing things of that, starting that. And then we are also just working in the community, checking on those we've heard that had breast cancer to see how we can help one another, and then help their families to become, like Dr. Sawhney said, a little more literate about the health, their health concerns, but also getting the word out to not only the family members, but also to the younger generations, because they don't see a need. They don't see a need to do anything. They're like, I'm healthy, so I don't have to worry about it. But I would say social media, if it's not social media, newsletters, pamphlets, or anything that can be brought to a church or a community that will help them to know that we are caring for you just as well.
I totally agree. And I think it's been shown that people don't learn or change their habits by, a written word or having someone from above say. It's who you know, it's who you talk to in your everyday life, it's your friends and your family. That's where we get our, the things that really influence our behaviors. And I really like the church approach with the Black churches. Not that everyone's religious, but everyone is connected to someone who's religious, and that gets it into the networks. And then also figure out the social media for the very young people too. I'm sure there are some people working on that. I'm not aware of exactly how they're going about it, because we know the problem of there also being misinformation on social media.
All right then. So Dr. Palmer, you are one of the original designers of the Black Women's Health Study, which I found really interesting. It's for the audience, a prospective cohort study of 59,000 African-American women that was begun in 1995. And your research looked at reducing death due to breast cancer in young African-American women, whom we always hear about associated with triple negative breast cancer. And I was wondering, were you able to find any factors that could be changed, that could be modified to help improve that particular group of women's overall survival?
Thank you for that question. That was indeed one of the primary purposes of our study. As you mentioned, the study's been going on for 25 years, and the National Institutes of Health have invested a lot of money in the study, as have the 59,000 Black women from across the U.S. who have participated and who every 2 years fill out another questionnaire. So it's a big effort, and we hope that important information will continue to come from it. And it was started because of this disparity, this difference in mortality rates from breast cancer, where Black women have a 40% higher mortality than white women. And even though mortality has gone down over time mostly because of improvements of treatment, that difference has stayed exactly the same over time. And we know some of the reasons, access to care and all of that. My own research has been trying to get at the prevention end, so of course we want to improve treatments and we want to improve access to care, but of course the individual woman would rather not get the disease if possible. Now, breast cancer is a tough disease. It's not like lung cancer where there's one primary cause. For lung cancer, it's cigarette smoking. So if people change that behavior, they're going to greatly reduce their risk. What we do know about breast cancer, it's what we call a multifactorial disease. There are many different factors that play a role, and each one influences the risk of disease by a small amount, but that's still important, especially for a common disease. So the other thing we know about breast cancer is that there are two main types, the estrogen receptor positive, which responds to hormones and is the most common in all populations, and the estrogen receptor negative, of which triple negative is the main type, which is less common in all populations than the first type, but it's twice as common in Black women as any other population in the US. We don't exactly know why, but it represents 30 to 35% of all breast cancers in Black women are this type. And also younger women are more likely to get it, and it's a more aggressive disease. Women who get it are more likely to die from it and to die in the first few years. So we're really trying to find out what are factors that can be changed that increase the risk of triple negative breast cancer. And I think the most important finding we've had from the study so far is that breastfeeding makes a difference. So if a young woman breastfeeds at least one of her babies for 3 months or longer, we're not talking about having to breastfeed for a year or 2 years. We're just talking about breastfeeding for at least the first 3 months, ideally 6 months. That reduces the risk of breast cancer, of triple negative breast cancer. And we don't know exactly why, but it has something to do with the changes that occur in the breast as a woman's body becomes ready for childbearing, for giving birth and then breastfeeding. And then what happens when a woman either stops gradually, discontinues breastfeeding, or abruptly, if she doesn't breastfeed, the breast goes through a lot of changes that can bring a lot of inflammation to the breast. So those are the hypotheses that have been put out there for the reason. Whatever the reason, we and now others have shown that breastfeeding versus giving birth and not breastfeeding will reduce risk by about 20%. So that's not a big reduction, but it's a meaningful reduction. And it's important for young women. It's something that young women or our daughters can do that will reduce their risk going on. So we have had education programs. When we first came out with this finding, I was collaborating with another group in Buffalo, New York, that had a different type of study of breast cancer in Black women, and we were working together. And we spent a day with the first ladies of all of the upstate New York Black churches. Well, maybe not everyone, but they represented 10 or 12 churches. And they also brought some of their younger generation, some friends. We spent the day with a couple breast cancer advocates just discussing breastfeeding and why Black women in this country are less likely to breastfeed than other groups. And there are a lot of very good reasons, including if you have to work and you work at a job where you can't take time to go in a private room and pump your breast. You can't stay home for 3 months, maybe, you have to go back to work more quickly. So there are a lot of reasons, but we were having this discussion and then it was videotaped and turned into a 5 or 6 minute video that has been now used as sort of an educational tool to get people talking about the benefits of breastfeeding with regard to breast cancer. So I would say that was one of our main findings, most important. Another one, which is probably needs to be verified a little bit more, although it's been shown in other populations as in Europe and in white US women, that women who eat more vegetables have a reduced risk of triple negative breast cancer or estrogen receptor negative breast cancer. The same wasn't true for the other type, but it seemed to be a risk factor. Again, I don't know the reasons for that, but I've seen it now in a number of studies. So those are two very modifiable things.
So very interesting. And those were applicable to the United States, correct?
Yes.
So Dr. Sawhney, in your international work, do you think there's an opportunity here to share these findings and apply them in other countries of the world?
Extremely, it's really, really important in US and other developed nations. I think there is at least a lot of, awareness. There is a lot of, support groups and everything. I work in very, low income, resource poor, and, very fragile health systems where, you know, a survival of a woman itself is a big question mark. Forget about women getting mammograms. So I think I have been working, I'm trying to set up a program with Rwanda Medical College, and they are interested in setting up few things where when women come for their antenatal care, or, you know, when women come for family planning services, that we do encourage women, we at least educate them that there could be a risk. And the challenge in developing countries is that in US, if I did a survey, I would at least find 60 to at least 50% of the women would say they have heard the word mammogram. They don't get it done. They don't, have resources. In developing countries, I'm originally from India and other Asian countries and East African countries where I primarily work, people don't even know what a mammogram is, or is there something of a preventive services. So yes, there is a lot of need and a lot needs to be done in countries where the risk is high and people have no knowledge or resources available.
Yeah. And Reverend, you and I were talking a little bit last week about access to grocery stores.
Right.
You know, here we just learned about a research finding where if you increase your intake of fresh fruits and vegetables, there's an opportunity here for younger African American women to have a better survival. How do we get that message out there now?
One of the things is that depending on where people are, food deserts, there's so many of them across the city of Charlotte, and you realize that people are not gardening. Most of the grocery stores are more than a mile away, and it's not within a walking distance. So you have that. You do have farmer markets, but most of those are open during times that if you are an essential worker, guess where you are? You're at work and you're not able to get to those places to pick up the fresh fruits and vegetables as expected. But also the cost of fresh fruits and vegetables is more than just getting stuff out of a can. And so you so it's like a trade-off. Do I go and get these fresh vegetables, which are going to cost me more in my budget, or I just kick off and get, just go to pick up the can and the stuff that's really not healthy enough. We know we talk about leafy green vegetables and that will help, but we might look at, well, I'll just get some corn or some carrots or something that is not just as nutritious as anything else. Especially, and this is my kick, iceberg lettuce, no nutritional value, none. And so those are the challenges that we have, just getting access to getting to the grocery store. Your corner stores will only supply a very basic, and may not be any vegetables at that time.
You know, where I worked in Milwaukee during the summer months, we were very blessed to have a co-op food truck come to our hospital once or twice a week, and they would bring homegrown vegetables to the hospital where caregivers and patients would come, and they would be able to buy these freshly grown vegetables right from the hospital and then take it home for dinner. So, I mean, it was really neat. It was, all right. Let's talk a little bit about predicting our risk for breast cancer. You know, we always hear that African American are at high risk for breast cancer, and particularly ages before screening mammography is started at the age of 40. Dr. Palmer, I understand that you're working on something that might help predict who is at risk for breast cancer, and talk a little bit about that.
Yeah, that's where my heart is right now, is trying to develop a more effective mathematical model that will tell for each individual woman, give it sort of a numerical estimate of how high her risk is of developing breast cancer. There's been a model like that called the Gale model. It's been around for about 20 years, and it's been used. Well, first of all, I should say it was developed in white women and tested in white women. And when we and others tested for Black women, we found it didn't perform very well. So it nevertheless, it's been the only model out there, and it's been used primarily to determine who is eligible for cancer prevention trials. And by those trials, I mean, for example, if there is a very promising drug that might actually prevent cancer, such as tamoxifen or raloxifene, a trial is done where people are randomized to that or a placebo, for example. But because they're bringing healthy people in and they don't want to wait 25 years to have enough events, they only want to have women at high risk in the trial, because that way those who are going to get breast cancer will get it sooner and the information will be available sooner.
Mm-hmm.
So they then would use this Gale model to find out who is at high enough risk to be in that trial. Well, as a result of using that Gale model for those trials, Black women were underrepresented in the trials because almost nobody qualified according to this model, because everyone was coming out as being at lower risk. So that's a big loss. And we, now everyone realizes there's a problem and we want to have more Black women in the trials. But if there's, say, something really good comes out that will have an effect in preventing triple-negative breast cancer, we want to be able to what's called stratify people according to risk for that trial. Prediction models are useful for another reason too, and this is what got me going, is right now our recommendations for going for mammogram are primarily age-based, and sometimes family history is also taken into account. But it's mostly, if you're such age, you should start going for mammogram every year or every 2 years. And we know there have been differences from the major bodies about what the recommendation should be. But we want to have a more personalized risk prediction that will tell especially younger women when they should start having a mammogram. So, we're having young Black women dying of breast cancer at age 38, 42, when they would not have ever had a mammogram. So their cancers are being picked up when they've already grown for a while and they are harder to treat. Mm-hmm. My intention with developing a better risk prediction model is for it to be used for young Black women to indicate who should be going for this mammographic screening or even other types of screening like right. MRI.
Exactly.
That will work better, that are better at picking up triple-negative breast cancers. So to do that, so my hypothesis is one of the reasons maybe the Gale model hasn't worked so well for Black women is that it didn't take into account the fact that breast cancer isn't just one disease, it's two main diseases, the estrogen receptor positive and negative. Maybe that didn't matter so much in the white population where it's something like 85%, 15%. But if it's 65-35, it's going to make a difference. And there are different risk factors for the two diseases, which we know there are some different risk factors. So the model I'm working on with some other people and putting together data from other studies as well is we're starting by developing two models, one for estrogen receptor negative and triple negative breast cancer, the other for estrogen receptor positive breast cancer. In the end, we'll have those two models to use for the purposes of prevention trials, but for the purposes of referring people, the woman needs to know, am I at high risk of getting breast cancer? No, no one really cares the type for that reason. So you can mathematically put that information together once you've developed the two different ones and come out for each person her own estimated risk of getting breast cancer at a given age. And once this is done and we've tested it and we've shown that it works better than any previous model, I want to get it out there to primary care providers. This is a model for people who, nurse practitioners, physicians who see women at the early ages who are coming in for a GYN appointment, whatever. There are going to be 6 or 7 easy questions to ask, or some of them will come right off the medical record, like weight and height. It goes right into a little calculator that does all the calculations and comes out with a number, and that will give the provider a way to talk with the woman and provide advice about screening. so that some people can go for either earlier screening, or some women who are already 50 or older, but maybe should be going for a different type of screening.
Right.
So anyway, that's my thing. I'm really think this has potential to help, and that's where all my efforts going right now.
It would be incredible if we could get that Gale model risk weighted just right with calculations that would more accurately predict their risk of developing breast cancer. But typically, if a woman's younger than, let's say, 50, her breasts are going to be quite dense. And you just mentioned that we have patients who are diagnosed in their 30s and early 40s. So in that group, Dr. Sawhney, their breasts are too dense for anything for screening mammography to be effective. Then we look at screening breast MRI, which is roughly about $4,000, including the radiology interpretation fee. So the Affordable Care Act, is there anything in the Affordable Care Act that would help cover this type of preventive screening? There's lots of programs for treatment once she's diagnosed with breast cancer, but what about screening?
I have not read the Affordable Health Care Act word by word, but
Sorry.
What I hear is that, I think more than the cost and the age and everything, I think at least sensitizing the population, what Dr. Palmer just mentioned, identifying that you might be at a risk, I think educating those women early on that, and this is what I was talking a little while ago about health literacy. I very strongly advocate not only, I have a PhD in public health. When I went for my first mammogram, let me be honest, I didn't know what was a 2D and a 3D mammogram. And this is a professor of public health who works in women's health, and I didn't have any knowledge. So I think more educating people, sensitizing people that you could be at a high risk is far more important. And then the next step could be, to work with agencies, to work with insurance, to work with Affordable Health Care Act, to see if there are provisions. My research is focusing on that, women don't even get to that level that I could be high risk, or I should, be considering that, I'm above 30 and, I think there has been, mixed research, whether screening should start at 35 or after 35, things like that. So I think sensitizing and providing health literacy to women that, for example, if we were to implement what Dr. Palmer is doing, if every primary care physician and nurse had a list or a database that, X, Y, and Z women in our area at high risk, there could be a follow-up service, there could be a follow-up program. Listen, now you are 40 plus and, a couple of years back, you were found to be high risk. Would you please consider, can we please, encourage you to get your mammograms? That I think is something that's missing that we really need to address.
Yep. So Reverend, I'm just running through my mind here. I have women who are at high risk, and these women need screening breast MRIs. At least they would get more benefit from the mammogram. But there can be a distrust of the healthcare system. So if I go to a young Black woman and say, look, according to Dr. Palmer's modified Gale risk model, you are at high risk for breast cancer, and screening mammography is not very effective in your case to detecting early breast cancer. Breast MRI is indicated. Now I'm recommending something that is somewhat claustrophobic, requires IV contrast, that costs 40 times more than the screening mammogram. How do I address that distrust? I mean, why would she agree to something like that when I can't even, when I have a hard enough time with screening mammography?
Well, let me start with my journey right quick so that you'll understand. I had a baseline at 35 years old so that they can find out what was, make sure we had a baseline. And when they did the baseline, everybody freaked out. Because I had a surgery. I had a hole in my heart vessel when I was born. And so that surgery actually created a lot of scar tissue. And so for that very first mammogram, everybody was on pins and needles at that time until they could figure out. And once I explained with the rest of the health issue that was there, they're like, okay. But we fast forwarded like maybe a few years later, I was about 45. and they saw they wasn't too sure what they saw in the mammogram that year. And they said, okay, well, we're just going to go do a ultrasound. And okay, ultrasound, okay, we could do that. But it wasn't anything. So they was like, we'll check. And the year that I actually missed my mammogram, because I was very faithful, I was so busy, I forgot to get it done the year before in 2015. So come to 2016, I was like, oh, I got to go get my mammogram done. So I got it done. And then right there, it was like, we need you to come back. Okay. So then I'm thinking a few years ago, oh, was it like they saw? Well, we don't know. We just need you to come back. And so when I went back, they checked, they did an ultrasound. Then they said, well, we need to do a biopsy. So now I'm like, biopsy? What's a biopsy? So now I'm like, I don't know any of these terms. So I'm walking with you. And then the biopsy came. Then they said, well, we need to inform you that you have cancer in the left breast. Okay, so I'm flat. There's nobody with me. I'm by myself getting this information. And then I go and they said, well, we need you to come back because we want to go and do I think it's the dye. Yes. They said, we want to see if it spread it anywhere. They did everything they could. They did an ultrasound. They did a CT scan. So, my insurance was going up and I'm like, well, how much is this costing me? Because I work a very full-time job. I have health insurance, but it was enough, but I still had to pay out close to $2,500 out of pocket to start. And from there, all of those tests didn't show anything of where the cancer was coming from. So they said I was stage 0. So then I went through the bilateral mastectomy. After the pathology report and going through, they found out it was stage 2B cancer. And I selected to do, both breasts. It's not just one. And all of the cancer was being held under this scar tissue. So when women hear stories like this, it's like, I don't know if I need to go, because if they did all those tests on you and they couldn't find out, well, why would I go and do that and they still can't find out, and I'm out of money, and then I have to figure out how to pay for it, and it's added to the extra bills that I have, or it's just extra because I don't have the income to support any out-of-pocket costs. So that's one of the things that I'm starting to see, and you hear, is that I'll just go get a mammogram, but if there's anything further than that, sometime we hear, well, I'll just pray about it and then keep it going.
Yeah, that's tough. I struggle with that walk through that decision making with my patients, and I do the best I can to tell them that we're going to be there, but sometimes it's a difficult conversation to have her trust us to say, okay, yes, we're going to take that next step. Well, for the audience, I want to just let you know that we have 15 minutes left in this discussion, and the questions are starting to fly in from our audience. And so if you don't mind, I'm going to start taking some of those questions for our august panel. And the first one comes from a research coordinator who states that there seems to be a trend of lack of awareness to resources for the community. And there's research supporting that certified patient navigators or champions that work with the preventive or treatment care team, the patient, and community resources to assist in breaking down the barriers. So for the panel, what are your thoughts on implementation of these certified patient navigators / champions to act as a liaison to providing and coordinating the patient to these resources, especially when we're talking about patients in socioeconomically challenged areas?
Well, I think it's been a fantastic program. Our hospital in Boston and several others in our area were among the first to try out patient navigation. I think the Komen Foundation funded some of those first efforts, and probably the NIH as well. And it's been probably 10 years since that whole thing started, and I hope it's spreading more. I know we're continuing it, and it started with breast cancer. We've been trying to expand it to other cancers and other treatments. Of course, that costs money. Although I will say it's not that the patient navigators are paid that much, because I know some people who've been looking for jobs, and it's a good job, but it's a not a high salary, which is what makes it affordable to be done. And people who get the training to do navigation have been excellent, and I think it's probably one of the best things we've had for helping people through the system. Although that said, just going back to the last conversation, without an overhaul of our health, the way we finance health in this country, we're still going to have a big problem, because those costs for those co-pays and all of that are not going to go away.
I know my patients are so grateful for the care that they receive from their cancer nurse navigators, who are usually the first person that they meet when they hear that they have breast cancer, and just helping them steer. Because like Reverend, you just said, you're an educated woman, but until you've actually been diagnosed with breast cancer, there's a whole dictionary of medical terms that come flying at you. Did you have a navigator invested in your care?
I started out with a navigator, and after my surgery, I didn't have one. Don't know, I didn't find out until a year later that she actually had died of breast cancer. And so I was kind of, I fell through the cracks. So I was a little angry, a lot angry. I won't say a little angry, because I didn't have anyone to walk through. I basically used the physicians to help me to walk through and navigate. Did some research on Google, everybody's other doctor, but did that research and just try to help myself through and see what else I can do with it. But what I hear now and what I'm seeing, it is the best thing to have. For those that I heard in groups that I was in, they were like, yes, I had one, and they were, they worked with me, they made sure I knew what I needed, and moved forward. But the only navigator can give you so much from a treatment standpoint, but there are some other things that no one talks about, what you really need when you go home.
Talk about some of those areas. Would you mind?
No problem. So one of the things that, they'll tell you about, okay, these are your drains. You could, that's trauma still, but these are your drains, how you clean this, how you do, how you take care of yourself, making sure you don't get infected. But what they forget to tell you is that you really will not be, if you had a bilateral mastectomy, and if you try to lay down in your bed, don't do it. You will not be able to get up. So preparing for a shower chair, preparing to have some way of having that mobility that you can get up with ease without straining yourself. Thinking about what's the best type of diet that I need to be on. Because you tell me I can go back to eating my normal food. What is my normal food? What's my normal diet? Let's change up on that. And just making sure you know where to go for support group, or how your family can take care of you with all the medicine that you have. I walked out of the hospital with a lot of medicine, and about after week 1, we threw the the oxycodone, no more. Couldn't do it, because it was just too much, and you had muscle relaxers and a few others, and you just had to know when you can take certain pills and when not to take certain pills. So we had a board of time, putting it up, what time to take each pill and what hours that they need to be there.
Yeah. Did you gain any benefit or exposure to integrative oncology services?
Yes.
What is that all about?
So I wanted to go vegan. They didn't do quite well. So I was trying to go vegan, and I wanted to know how can what changes do I need to make in my diet? I read in a research somewhere that, soy is not very good for Black women, or just soy is not very good. So I was like, well, let me kind of cut soy out. And when you read all your packages, you have soy and everything. So I asked my oncologist, I'm at Novant. So the cancer support center there referred me to Dr. Russ Greenfield, which is the integrated medicine oncologist. And we had this conversation about maybe more of homeopathic medicine. So acupuncture, yoga, supplements that will provide, energy, things that, meditation, mindfulness, all of that to help within my, with my diagnosis, but also help me to get to a point where I can rest a little bit easier and not be, not be angry about having breast cancer. Those are the things that help me to see how I can make a change in my life, and see what I can do. And so instead of going to, one of the massage places, you can actually go to there's a person that specializes in massages that knows the spots, especially for a breast cancer patient, knows where those scar tissues that are sitting there to help ease things out. And that's what it's all about, just making sure there is an alternative, but it's not an alternative that you may not go through chemo and radiation. Although I went through radiation, I still went to the oncologist, the integrated medicine oncologist, to see what are some things that would interact differently with the medicine that I was given. So I started out with tamoxifen, and I'm on anaroxol, I think. Yeah, that one.
Aromatase inhibitor?
Yes, so I'm on that, the second one now, and what we found out, that if you do a lot of turmeric,
Mm-hmm.
it does not do well with that medicine. So I love it because I'm getting the information of what will block the medicine that I'm taking, and especially the things that I will normally do.
Yeah. Soy, not good for Black women. I did not know that. Dr. Sawhney, you've been all over the world. Have you heard that before?
No, and I'm very curious to listen about this turmeric thing, because my cooking is primarily Indian and we cannot cook without turmeric. So I think it's another very good thing to have. But I wanted to add one small thing to the question that you asked, and I think I've experienced that not just in the US, but world over. When we talk about this patient navigators and champions, I think identifying somebody and training somebody from their own community has shown to have much more impact. Think about me, from being a professor, going to Tanzania, talking to people. Oh, I did all this fancy research and you need to do X, Y, and Z. It will not have that lasting impact if a girl or if an older woman or a person from the community says, listen, girls, you need to get your mammograms done. And I think a very well documented example is I also worked for WHO for polio eradication. And one of the most successful factors for eradicating polio, especially in tricky countries like Nigeria, the reason they could do was they involved the religious and the local leaders. Rather than a UNICEF official coming and saying, please get your kids vaccinated for polio, it did not work for years. But asking a local, a community leader or a religious leader, Nigeria was polio free in a couple of years. So I think even we could implement the same here, identifying, training, and that doesn't have to be, get a degree certificate or things like that, but that would also encourage people to feel that their health is important and there is not something our research is imposing on them. So, empowering them, making them feel that one of their research, one of their health issues is taken as an important, I think that will be a longer sustainable plan rather than one of us going to the community and, educating them.
I agree with you 100%. I was involved in an organization back in Milwaukee, which is now national, called the After Breast Cancer Diagnosis group. And it was started by Melody Wilson, who was an anchor in the news world. And she had access to all the best doctors in the state because of her position, and everybody knew her. But she realized that as great as her healthcare team was, because they'd never gone through breast cancer treatment before, they didn't quite know what it was like to walk those shoes and what she was going through. And so what she did was she took other breast cancer survivors and brought them to a level of education so that these breast cancer survivors could objectively get to the community, just like you said, people that looked like them, was diagnosed with the same stage breast cancer, had the same kind of career or life challenges or social determinants of health, and were able to get through the treatment in spite of all of that. And that was someone that they could trust. That if it was coming from this other woman who looked like her, sounded like her, had a similar experience, those were women who could be trusted. And I agree with you 100% there. All right, in the last 4 minutes, Dr. Meg, did you have any other questions for us or closing comments?
I just wanted to thank you. We do have another question from Nicole Goolsby. Are there suggestions to increase awareness of genetic mutations and the availability to have that tested, especially ATM mutations prior to having a cancer diagnosis?
Oh, goodness.
Right.
All right, excellent question, Ms. Goolsby. So most breast cancer occurs as an accident. Changes occur in the cell, nobody's fault. But about 5, maybe 10% now of breast cancers we know are actually attributed to genetic mutations. So changes in our DNA that we are born with that predispose us to a higher risk of breast cancer, usually because the mechanisms in our body that are usually used to suppress tumors are now no longer functioning correctly. And so these genetic mutations increase your risk. So we have now the ability to test for many of these genetic mutations, not all of them, but as we become increasingly more aware of them, we are able to test for them. And it's a matter of getting out to the community, asking patients who in their family has been diagnosed with not just breast cancer, but other types of cancers that are associated with known syndromes. So for example, most people have heard about the BRCA1 and 2 mutation affecting Angelina Jolie. And that affects women who have a family history of breast cancer, ovarian cancer, pancreatic cancer, and melanoma. And when we start to hear other people in the family diagnosed with these, we then ask, preferably somebody who's been diagnosed with cancer, but if not available, then whoever is asking the question to give some blood, and then we can do the genetic test. Again, it's a matter of community awareness to let people know that we want to understand who else in your family has been diagnosed and with what kind of cancer and what ages. And so when you gather with your family in these social settings, ask, communicate, share that information with each other. I just heard that Aunt Betty was diagnosed with breast cancer, and then my cousin Michelle was diagnosed with ovarian cancer, and then Uncle Pete was diagnosed with prostate cancer, and he was only 40. Get that information, record it, so that you can share that with others in your family. And you never know, sometimes that information can be helpful to the person in their family who's diagnosed with cancer.
Thank you. I want to thank each and every one of you, Dr. Palmer, Dr. Tjoe, Dr. Sawhney, and Reverend Ar-Rahmaan. Thank you so much. This panel has been absolutely informative, inspirational, and so helpful for everyone in the community. Thank you for the work that you're doing. Thank you for your passion around this work. Thank you for your research, and thank you for this very important and on-time discussion. I appreciate all of you, and I wish each and every one of you well. Thank you. Again, I want to invite everyone to, yes.
I want to take this opportunity to thank Dr. Michelle and of course Taylor.
Yes, Taylor.
So, diligent in sending reminders and coordinating things. So thank you, Ms. Taylor.
Thank you. And
thank you, Dr. Meggs and Dr. Tjoe. It was an honor to be part of this amazing panel. Thanks all of you.
Thank you for your research and continued work. We look forward to hearing from your publications.
Yes, and I want to invite all of our viewers to our intimate partner violence discussion next month, November 10th at 12 o'clock. Again, thank you everyone for your willingness to share. Reverend Ar-Rahmaan, for your vulnerability and willingness to share your experience. Thank you so very much. I know that you've helped so many people with your story.
Thank you. Be well, everybody. Stay
Be
safe.
well. Take care, everyone.
Once again.
Have a good day. Thank you.
Bye-bye.
Bye.